You don't need to be dangerous to need help. You just need to be honest. Maybe you told your primary care doctor you're not sleeping. Maybe you called your insurance provider and asked for a therapist. Maybe you typed, "I need help" into a search bar, stared at the screen and closed the laptop. That's how it starts. Not with a breakdown, but with a system that doesn't know what to do with the beginning. In America, access to mental health care isn't about how sick you are. It's about who you are. If you have private insurance and live in the right zip code, you might get a therapist in 2 weeks. If you're on Medicaid, or uninsured, or rural, good luck. The line is busy, the wait list is full, the office is closed. Most people don't get a human, they get a voicemail, then paperwork, then a denial. According to the National Council for Mental Well-Being, more than half of US counties have 0 psychiatrists. And in emergency rooms, people in mental crisis wait longer than any other patient group, often over 12 hours. By then, the question isn't, how do we help? It's, what do we do now that it got worse? That's the American model. Document, delay, discharge. It's not a lack of resources, it's a lack of urgency, until it explodes. Welcome to PaperLoud, where silence ends and real questions begin. Today we're talking about a system that's everywhere and still fails millions every year, mental health care in the United States. We'll show you why help often arrives only after collapse, why therapy becomes a maze, why pills replace people, and why in this country silence often feels safer than asking for help. If you think this doesn't affect you, listen closer. Because when systems fail the most vulnerable, they're already failing all of us. Insurance denied, when paperwork becomes policy. In the US, mental health coverage is a promise until you try to use it. You call your provider, they give you a list, you call the names on that list. Most don't answer. Some say they're full, a few don't even offer therapy anymore. The rest, out of network. And even if you find someone, there's no guarantee you can afford to go back. Here's the catch. The Mental Health Parity and Addiction Equity Act of 2008 legally requires equal coverage for mental health and physical health. But in reality, enforcement is weak. Insurers create narrow networks, limit sessions, deny reimbursement. Not because treatment doesn't work, but because delay saves money. For low-income patients, it's worse. Medicaid only covers what it can find, and in many states, finding a Medicaid-accepting therapist is like finding a unicorn with a license. Rural areas, desert zones, urban clinics, booked solid. So what happens? People give up. They go silent. They wait for it to pass, or for it to break them. And even when they get in, the paperwork doesn't stop. Prior authorization, session caps, appeals. The therapy room isn't a sanctuary, it's a spreadsheet with a couch. This isn't policy failure by accident, it's design. Because in a system built on billing codes and managed care, the question isn't how do we help, it's how much can we deny without being sued. Meds. First, questions never how the pill became the protocol. When the system can't offer care, it offers pills. For many Americans, antidepressants aren't the last resort. They're the first and only. You walk into a primary care visit, say you're anxious or down, and leave with a prescription. No therapy, no plan, no real conversation, just chemical hope. This isn't malpractice, it's protocol. Why? Because therapy takes time. Pills don't, because trained therapists are in short supply. But prescribing privileges? Widespread. Because insurance reimburses 15-minute med checks, but not 50-minute talk sessions. And because the system isn't built for healing, it's built for throughput. According to CDC data, 1 in 4 American women over 40 is on an antidepressant. Many of them started with stress, loss, burnout, isolation. But rather than being heard, they were medicated, quickly, permanently. And once you're in, it's hard to get out. Try asking for therapy. You'll be told to stabilize first. Try tapering off. You'll be told it's risky. Try switching meds. You'll be warned you might crash. There's no exit ramp, only maintenance. For some, meds are life-saving. For many, they're numbing. For others, they're just the easiest option in a system that has no time to care. We didn't over-medicate by mistake, we did it by design, because it's cheaper to sedate than to listen. Crisis as a doorway. Why help only comes after collapse. You can be struggling for months, quietly, hoping someone sees it, but unless you say you're suicidal or unless something terrible happens, there is no fast track, no safety net, no one coming. In much of America, mental health care doesn't begin until it's an emergency, until you're in danger to yourself or others, until someone calls 911, not because you're violent, but because it's the only number left. Then things move fast. Police arrive. You're handcuffed for your safety. You're transported, evaluated, maybe held involuntarily, maybe medicated without consent. It's called crisis intervention, but it feels like arrest, and it's not rare. More than 2 million people with mental illness are booked into US jails every year. Often, the jail cell comes before the hospital bed, because it's open, funded, and available. Hospitals, they're full. Psych beds have vanished, cut in half since the 1990s. Community care centers, closed due to budget, outreach programs, underfunded, understaffed, unprioritized. So we wait for someone to break. In Norway, a person in crisis can walk into a crisis center. In the Netherlands, you get a same-week home visit. In the US, you get an incident report. We don't prevent collapse, we process it. Because in American mental health care, the only door that opens easily is the one marked emergency. Final section. This isn't broken, it's designed. This way. People say the system is broken, but broken implies it once worked, that something failed, that someone forgot. What if this is what it was always meant to be? A system that filters based on income, that gives access based on zip code, that medicates instead of listens, that criminalizes instead of cares. We built mental health care around denial, around avoidance, around thresholds no one wants to cross. We wait until people collapse, then ask why they didn't ask for help sooner. We give hotline numbers instead of support, pills instead of time, silence instead of presence. And we wonder why things get worse. Mental illness isn't rare, it's not fringe, it's everywhere, in schools, in offices, in homes. But we still treat it like a defect, a deviation, something to manage quietly, preferably off-screen. Real reform doesn't start with funding. It starts with belief that mental health isn't a luxury. It's infrastructure, like clean water, emergency rooms, public safety. If we treated it that way, lives would change, and lives would be saved. Have you or someone you know been denied care, been told to wait, to calm down, to call back later? Then your story matters. Tell it. Share it. Break the silence, because this system won't change on its own. And the longer we wait, the more people fall. Share your story. Break the silence. Ask the hard questions. If this video made you pause, think, or feel something, don't scroll away. Add your voice to the debate. That's how change starts. And if you believe more people should hear this, subscribe to PaperLoud, comment, share, talk about it. Because staying quiet never saved anyone, but staying loud just might. Until next time, stay loud, stay sharp, stay human. Take care.